long-term outcomes of partial calcanectomies. The goals of this talk is to discuss indication for partial calcanectomy, barriers to healing. We'll talk about results and outcomes in the literature. We'll also discuss functional status of patients undergoing these procedures. And then we'll end by discussing pearls to successful outcomes. I have no disclosures for this talk. We all agree that dealing with heel ulcers, whether they're posterior heel ulcers or plantar or both, probably the most difficult ulcers to deal with. And there are many reasons why they're difficult to deal with. The main reason why they develop them in the first place is what makes them difficult to deal with. But also, it's located in an area that has poor perfusion to begin with, and there's not much soft tissue to protect the bone. So we know that they're very difficult to treat. Often conservative treatment fails. Split thickness skin grafts are typically not very durable in this area. We do see occasional regional flaps by plastic surgeons, and they do work occasionally in rare situations, but they're not very commonly done or shouldn't be very commonly done because these are difficult patients. Usually these are patients with poor arterial disease, and of course, they're debilitated. We also know that these ulcers tend to occur in patients with PAD and patients on dialysis as well, and of course, patients with diabetes. And finally, these ulcers do typically lead to below-the-knee amputations if not treated appropriately or aggressively. So what are the indications for partial calcanectomy? Well, there are a few. The major indications are stage 3 and stage 4 pressure ulcers. So stage 4 pressure ulcer is going to be down to bone. Stage 3 is not a solid indication for partial calcanectomy. However, in certain cases, when you have a stage 3 and you have subcutaneous fat exposed and there's no adequate granulation tissue and there's no way for it to build granulation tissue, then that may be a reason to go on to a partial calcanectomy. Certainly osteomyelitis of the calcaneus is a reason for partial calcanectomy. You can see here a picture of a chronic ulcer in the posterior heel with an X-ray showing erosion of the plantar posterior cortex consistent with osteomyelitis. Before embarking on a partial calcanectomy, we must assess patient's ability to walk or patient's ability to transfer. If the patient is not able to transfer, if the patient is completely bedbound, you need to reconsider doing this procedure. Because if the patient is unable to transfer, there's no reason to put this patient through a procedure like this. And plus, it's going to be difficult to offload this and to heal an incision that's typically performed on the back of the heel. So they must be able to transfer. They either can walk or they must be able to transfer. Finally, before embarking on this procedure, assessing arterial perfusion is paramount. Majority of these patients are elderly. Majority of these patients have arterial disease. So if you look at this heel eschar, the heel eschar is there because there's local thrombosis of the vessels and there's localized ischemia. But that localized ischemia may not only be there from pressure, it may also be there from macrovascular disease. If you look at the angiogram on the picture below, you can see that there's good anterior circulation, there's good anterior tib flow into the dorsalis pedis, and then there's some collaterals, but there's absent posterior tibial artery. So when you're doing these procedures, you have to assess blood flow. The most important artery here is going to be posterior tibial artery. If you, again, looking at the picture on the right, you can see that the heel gets its circulation from posterior tibial artery, but also from a branch of the perineal artery. So if the revascularization is attempted, you need to have this discussion with the vascular surgeon or the interventionalist, because the most important two arteries to reperfuse are going to be the perineal and the posterior tibial. That's the angiosome. Those are the arteries supplied to the posterior heel angiosome. If you have good anterior tibial flow, you may not be able to heal the heel incision or the heel ulcer. The surgical technique for partial calcanectomy is called the Reyzelman incision. This was described years ago by Reyzelman. This incision takes off from the Achilles tendon in a linear fashion across the heel and into the origin of the plantar fascia. And you can see how medial and lateral flaps are created, and you need to maintain the thickness of the medial lateral flaps in order to expose the calcaneus. And this is the best incision to accomplish that. It's also important, if possible, to have this patient in a prone position, because it becomes very difficult to do it in any other position if it's not prone. Looking at the radiographs of the amount of calcaneus resected, the x-rays are showing you how aggressive you need to be. A common mistake is made when we don't take enough of the calcaneus. And I'll show you literature and evidence in literature to show that, to demonstrate that aggressive calcaneal resection is really the way that we need to approach these surgical procedures. The picture on the top right is showing you how a contour of the calcaneus is maintained during the procedure. There are significant risk factors for poor outcome. And think about the type of patients that we typically operate on when it comes to partial calcanectomy. They have PAD. They are dialysis. They usually have poor nutrition. Many of them are diabetic. Many of them are elderly, so they have functional decline. They may not move that much, and many of them have osteomyelitis. And you put all of those together, those risk factors are pretty severe. Every one of them, in and of itself, is a risk factor for poor outcome. But when you add them together, they're significantly worse. So before embarking on a partial calcanectomy, we tend to ask some questions. And I think these are the questions that you need to ask yourself and discuss with the patient to understand and to figure out whether this is the right procedure for them. First, how likely is it to heal? You need to assess the healing factors. What is the perfusion? How long will it take? How long will the healing take? You should have some benchmarks to tell the patient, because they need to buy in to how long it's going to take. How aggressive should I be? How much calcaneus should I resect? And then, as we talked about earlier, is the patient able to walk on it? Is the patient able to transfer? Can the patient perform daily tasks? And can the patient maintain independence? All of those questions should be discussed and entertained before embarking on this procedure. So I want to go over some of the evidence and literature to support partial calcanectomies, or talk about healing outcomes and what are the important points to take away. One of the largest studies that was performed on partial calcanectomies was published in 2007 in JFAS by Cook. This was a retrospective study looking at partial calcanectomies and the factors influencing their outcomes. There were 50 partial calcanectomies reviewed. The primary objective was to determine what factors affect healing. They obtained 71% closure rate after 1 year and 76% beyond 1 year. Average time to closure was 201 days. And I want you to remember this number, because this is a significant number. It's not 6 weeks, it's not 10 weeks, it's not 12 weeks, it's 201 days. That's 6.5 months, or almost 7 months. 65% required vascular intervention in their group. And what they found was that BMI had no effect on healing time. Smoking took a little bit longer healing time, but wasn't statistically significant. Length of time also present had no bearing on outcome. They did find that low albumin levels tended to trend to longer healing. MRSA presence led to longer wound closure, and wound grade played a role in healing. So higher wound grade, higher grade Wagner grades certainly played a role in wound healing. They also found that 40% had an ulcer recurrence in 6 years, within 6 years. And again, this is an important concept to understand. These patients, once you get them to heal, have a high recurrence rate. So there must be a significant and thorough surveillance process and appropriate offloading for them after you get them to heal. A little bit over a quarter of their patients went on to a more proximal amputation. And dehiscence of the surgical incision occurred in both patients who had PAD and patients who didn't. But the patients who did have PAD had 88% of those patients dehisced their incision. Another study, this was a systematic review of 16 studies, was published in 2012 by Valerie Shade. And she looked at 16 studies that encompassed 100 patients. Mean follow-up was 33 months. 10% went on to proximal amputation. 85% maintained or improved ambulatory status postoperatively, and only 3% decreased ambulatory status postoperatively. And it's important to keep in mind the functional status. We talk about healing, we talk about recurrence, but we also need to look for functional status. How functional are these patients? Great, we took them to surgery. Great, we got them to heal. But what is their functional level? Is it even worth doing this procedure? Another study was published in 2015 by Steinberg and his group from Georgetown. And this was the first time that a study looked at lower extremity functional level after partial calcanectomy. Again, you can see the Gainsland incision, how the medial and lateral flaps are created. You can see the amount of calcaneus resected on the right side with the x-rays here. The demographics are interesting. Again, points out to what we talked about earlier. Greater than 80% of their patients were diabetic. Greater than 50% of their patients had PAD, and about just a little bit over a third were on dialysis. So again, the point that we're operating on these complicated comorbidities. These are high-risk patients. They divided their patients into two groups. They divided them in a group that resected less than 50% of the calcaneus and a group that they resected more than 50% of the calcaneus. And their results showed in the group that had less than 50% resection, they actually resected an average of 13%, which is very low. In a group that they resected greater than 50%, they resected a mean of 74% of the calcaneus, so pretty significant. They had about 29% patients go on to a below-the-knee amputation. Mortality was 12%. Lower extremity functional score was 33.9 or 30 and 36. So let's look at what that really means. So if you look at the lower extremity functional scale, you can see that 36% means that they had quite a bit of difficulty with function. We looked at our own results and our own experience at UCSF, Center for Limb Preservation. This study has been submitted for publication, so it hasn't been published yet. So this is hot off the press. We looked at 35 patients between the years of 2012 and 2018 that underwent partial calcanectomy. 35 patients and 39 limbs with a minimal follow-up of 1 year and a mean follow-up of 2.3 years. Average age was 61. 80% of our patients had diabetes, 62% had PAD, and 23% were on dialysis. So again, very similar to the cohort from the Georgetown group. What we found was that 18% of our patients went on to a below-the-knee amputation. Average time to a below-the-knee amputation was 5.5 months, and we had a mortality rate of 17%. 30 patients, or 77%, healed. So our healing rate approached the same that was described by Cook in 2007. Average time to heal was 230 days. And again, if you remember that number from Cook's study, I showed you it was 201 days. So now we're reproducing these numbers with another study. They're very similar. We now know that these patients take a long time to heal. 21 limbs. What's interesting, in our group, we looked at the type of closure. We wanted to see whether it mattered whether the patients were closed primarily or they were left open to heal by secondary intention. And what we saw was that the 21 limbs that were closed primarily healed in a mean of 200 days versus the 9 limbs that were left open to heal by secondary intention healed in greater than 300 days. Although this was not statistically significant because of the low end that we had, there was a little trend that we weren't surprised to see. What else did we find? We found that the recurrence rate was 57%. Again, very high. In my opinion, this is very high. Not unexpected, but still high. 40% recurred within the first year. So there were 12 limbs that recurred within the first year. What's interesting is that even though 17 limbs that had recurrence, 16 of the 17 actually were able to heal completely with just conservative care. And what does that tell us? That tells us that even if they dehisce or if they don't heal, if they recur, we can go ahead and heal them and still prevent them from going on to a below-the-knee amputation because one of the 16 went on to a below-the-knee amputation. Perhaps the most interesting part of our cohort was the functional outcome. We really wanted to see what is the functional outcome of these patients. And we looked at the functional outcome based on this chart. We divided the patients into several groups. Those who were bedbound, those who were wheelchair bound, those who were ambulatory for transfer only, ambulatory with assistive device, and what that means is they were either wearing an AFO or they were wearing a boot or they had some form of an orthosis or a cane, and those that had no assistive devices, fully ambulatory. So out of the 30 that healed, 60% had no change in functional status from baseline, which means that if they were ambulatory without assistance, they still stayed ambulatory without assistance. If they were ambulatory for transfer only, they stayed as transfer only. They didn't lose a grade. 3 limbs, or 10%, had improvement in functional status from baseline. What that means is that patients who were ambulatory for transfer only, they may have improved to ambulatory with assistive device. Or those who were that wheelchair bound improved the grade to ambulatory for transfer only. And 9 patients, or 30%, had decrease in functional status from baseline. And it's worth explaining what that means, because in certain terms, we actually expect some of these patients to decrease in their functional status. So if you had a patient that you operated on that was ambulatory without any assistive devices, well, certainly after getting a partial calcanectomy, you expect them to have an AFO or some form of foot orthoses in order to ambulate. So that's an expected type of decline. So in summary, what are the take-home points and the key insights that we can assess from partial calcanectomies? 1, partial calcanectomy is a viable alternative in an appropriately selected patient. 2, there's a large body of evidence that supports partial calcanectomy procedure that is a good limb salvage procedure. 3, aggressive resection is preferred. If you're contemplating doing this procedure, you should be taking at least 50% of the calcaneus or more. Expect a protracted course for healing. You should have a talk with the patient or their family and say, look, we're actually going to expect 200 to 240 days for this to get better. Are you in? Do you buy in? And that's an important concept, because if they don't want to do this or they can, then maybe a below the knee is the right procedure. Preoperative functional status is preserved postoperatively. So we can safely say that majority of these patients, of course, some of them do decline, but for the most part, they either stay the same or they may improve a little bit. Patient expectations, quality of life, and independence are factors to evaluate preoperatively when considering this type of procedure. Thank you.